during the observance of World Antimicrobial Awareness Week. Myself, Dr. Kavita Sarau, Professor and Unit Head in the Department of Infectious Diseases and Coordinator of MACID. I'm pleased to welcome all of you and to host this webinar series with one international speaker and a national speaker every day over the next 6 days. We are delighted to have participants joining us from across India who share the collective commitment of clinicians, scientists, students, and public health professionals to address the growing challenge of antimicrobial resistance. World Antimicrobial Awareness Week is a time for us to reaffirm our commitment to prolong the effectiveness of antimicrobial agents and to strengthen antimicrobial stewardship practices. As we come together to learn, to share insights, and to reaffirm our responsibility in safeguarding the effectiveness of these essential medicines for future generations, let us go straight into the first presentation by Sagarika Nanda. She will be speaking on a very important topic of approach to pyogenic meningitis. This is a condition which is very fatal and requires antibiotics quite as soon as possible. However, we should also observe stewardship practices even while managing pyogenic meningitis. Dr. Sagarika Nanda, she is an associate consultant at Apollo Hospital, Hyderabad. She had training for MBBS and MD medicine from Kasturba Medical College, Manipal University, Karnataka, and FNB in ID from Apollo Hospital, Jubilee Hills, Hyderabad, Telangana. She has special interest in community-acquired infections, tuberculosis, HIV, transplant-related infections, and evidence-based clinical care. She has won several prizes for her oral and poster presentations and quizzes at national level. Over to you, Sagarika. I'm very happy to have you as a presenter. You can share your presentation now. Participants, if you have any questions, you can put it in the chat box and stay muted at all times.
Is my slide visible now?
Yes, you can put it in the presenter mode.
Good evening, everyone. Thank you, ma'am, for giving me the opportunity to speak today. As we mark Antimicrobial Awareness Week, it's important to revisit conditions where our antimicrobial choices truly matter. Pyogenic meningitis is one such emergency where treatment must be immediate, targeted, and responsible. So today I will talk on approach to meningitis with a focus on pyogenic meningitis. What will I cover today? So most importantly, I will be dealing more with pyogenic meningitis and its approach, definition, etiology, pathogenesis, clinical presentation, and evaluation. It will be mainly a case-based approach and focus on treatment and prevention also. So moving on, what is bacterial meningitis? Bacterial meningitis is a purulent infection within the subarachnoid space. Inflammation of the meninges surrounding the brain and spinal cord typically characterized by headache, neck stiffness, and CSF pleocytosis. Encephalitis is a mimic wherein inflammation of the brain parenchyma occurs, and hallmark of which is encephalopathy or diffuse alteration of the brain function, which presents commonly with altered mental status. So mostly there is an overlap seen in presentation of meningitis, wherein meningoencephalitis where evidence of both meningeal and parenchymal inflammation occurs. What is the etiology? The etiology of pyogenic meningitis mostly is based on the age and risk factors. Considering the age of presentation, the most common cause in non-immunocompromised adults is pneumococcal infection, that is Streptococcus pneumoniae, and meningococcal infection. In neonates and elderly, Listeria meningitis is an important cause of pyogenic meningitis. Coming to the pathogenesis of pyogenic meningitis, usually occurs secondary to nasopharyngeal colonization by the bacteria. So the bacteria, which is most commonly pneumococcus and meningococcus, they are present in the nasopharyngeal region, which leads to colonization and invasion into the bloodstream, because of which there is bacteremia. Hence, the load of the bacteria increases and it leads to crossing of the blood-brain barrier via the endothelial cells. So, rapid multiplication in the CSF after entry into the subarachnoid space occurs, especially in conditions where there is a poor host defense. So in such situations, CSF multiplication of the bacteria leads to production of toxins, which activates the cytokines like TNF alpha and causes inflammation of the meninges. Most of the complications which occur is secondary to cytokine activation, leading to inflammation, vasogenic edema, and raised intracerebral pressure. What are the organism-specific risk factors that we need to see when a patient presents in the emergency? Whenever a patient comes with a syndromic diagnosis with the classical triad of fever, headache, knuckle rigidity, there are important risk factors which needs to be considered in the diagnosis. So when we examine a patient, if there is a contiguous infection focus, like there is otitis media, sinusitis, mastocytitis, and there is a skull-based fracture leading to CSF leak, also factors like asplenia, immunocompromised states, and in setting of outbreaks in correct epidemiological setting, pneumococcal infections are considered. Now, meningococcal infections have reduced due to the vaccination, but in overcrowding, Hajj and Umrah mass gatherings, where there is in areas where there is low vaccination coverage, especially in the African meningitis belt, which in the dry season, patients present with meningococcal meningitis, and other risk factors which point towards meningococcal infections are again complement deficiency and immunosuppressed hosts like HIV and asplenia, as these are capsulated organisms and they are mostly destroyed in the spleen. In asplenia, the meningococcal, pneumococcal, and H. influenzae infections are more common. Now, major cause of meningitis in children who are unvaccinated and adults who are unvaccinated and also in less than 5 years age is Haemophilus influenzae. After the immunization program, there is a reduction in overall incidence, but non-B serotypes is increasing, and non-typable strain causing meningitis is more seen now. Now, when do we suspect Listeria meningitis? When a patient presents with pyogenic meningitis, considering the age factors, as we discussed, neonates and elderly above 50, above 60 years of age, pregnant women, and also foodborne exposure, like people who consume in this setting unpasteurized dairy products, deli meats, and refrigerated food, as Listeria can grow or multiply even in refrigerated conditions. Also, common cause of infection in pregnant women and immunosuppressed hosts, especially transplant recipients. So when do we suspect Hib meningitis? When Hib meningitis or pneumococcal meningitis occurs in children despite vaccination, there is it is reasonable to evaluate for underlying immunodeficiencies. So in the setting where patients have vaccination history, they have been adequately vaccinated, but present with recurrent infection, malnutrition, growth, stuttering. In these patients, it's ideal to always look for underlying immunodeficiency. Even Howell Jolly bodies in peripheral smear indicates splenic hypofunction, and it can give a clue to these capsulated organisms causing meningitis. Moving on to the other risk factors which point towards meningitis due to group B strep, that is strep agalactiae. It's seen commonly in neonates and infants in less than 3 months of age, and it's commonly secondary to maternal GI or genitourinary colonization, and commonly seen in this postpartum women. So when a postpartum woman presents to us in the early neonatal, if the patient presents to us when a neonate presents in the early phase and there is a history of maternal GBS colonization, this is an important risk factor which should be kept in mind and considered. Even elderly and patients with comorbidities present with group B strep pyogenic meningitis. Coming to infants, immunosuppressed individuals, severe malaria, sickle cell disease, hemoglobinopathy, these risk groups are more commonly non-typhoidal salmonella meningitis occurs. So it's a high burden in sub-Saharan Africa. In setting of pyogenic meningitis, there are other infections which present subacutely to chronic. In the early phase, these can mimic a pyogenic meningitis. Important differentials to keep in mind are tuberculosis, brucella in the correct epidemiological setting and exposure to livestock, leptospira, Lyme's disease, syphilis, and rickettsial illness. Rickettsial illness is kept in mind when the patients have a exposure to ticks, especially with the visit areas with scrub and have tick bites, which predispose to meningitis due to scrub typhus or other rickettsial organism. Now, the other mimic which has to be differentiated when these patients present is a viral meningitis. So usually, like it's overlap syndrome, most of the patients who present with the acute pyogenic meningitis, they have at least some percentage of these patients present with the altered mental status and seizures. Important viral infections to consider are enteroviral meningitis, herpes group, especially HSV2 meningitis, which patients present with recurrent meningitis, also called a Mollaret's meningitis kind of presentation. Arboviral infections like JE, Japanese encephalitis, and tick-borne encephalitis, and other viral meningitis secondary to HIV, measles, mumps, influenza, which present with aseptic meningitis. So the risk factors and the clinical features differentiate, and also the CSF studies help us in differentiating viral in comparison to bacterial meningitis. So now I would like to go ahead with the case so that we can discuss as a case-based approach to how do we get into a syndromic diagnosis and consider our differentials. So a 32-year-old male from Andhra Pradesh with no significant premorbid illness presents with a 3-day history of high-grade fever. So this gentleman was apparently well till 3 days back and presented with high-grade fever, severe headache, recurrent vomiting, and family reports confusion and irritability, which has been there since the past 12 hours. There is no history of travel or sick contacts, no premorbid illness. The vaccination records were not available, but childhood vaccinations were up to date. So when we see in our ED a patient who has presented with such a history, we look for clinical signs which can give us a clue to diagnosis. So syndromically, this is a acute meningitis syndrome. On examination, the patient was febrile, vitals were stable, BP was 100/60. So a head-to-toe examination needs to be done. It's crucial to rule out viral and rickettsial illness and meningococcal meningitis. So there is no petechiae or purpuric rash, hence meningococcal meningitis is unlikely in this patient. Though it can be an early presentation, he's not in shock. Head-to-toe examination shows no eschar. And neurologic examination, he's disoriented. There was positive neck stiffness, photophobia. There were no focal neurological deficits, and fundus examination shows no papilledema. Presentation-wise, the syndromic diagnosis of acute meningitis syndrome is considered here, as he presents with a classical triad and of fever, headache, knuckle rigidity, and altered sensorium in the last 3 to 4 days, and he was apparently well. So the probable bugs that we consider here are pneumococcal meningitis, meningococcal infection, Haemophilus influenzae, and viral etiologies like HSV, enterovirus, which is unlikely here. It's a very acute fulminant presentation with severe headache and high fever. So likely causes a pneumococcal meningitis or Haemophilus influenzae meningitis. So how do we proceed here? Should we start the patient on empirical antibiotics with steroid like dexamethasone? Should we image the patient? Go ahead with imaging. What do the new WHO guidelines recommend? So performing cranial imaging to rule out a cerebral space occupying lesion with midline shift is considered only in the presence of following conditions: where there is a low Glasgow Coma score of below 10, there are focal neurological signs, cranial nerve deficits, papilledema, a new onset seizure in an adult, and severe immunocompromised state like transplant recipients. In this presentation, our patient had no focal neurological deficit or papilledema or seizures. We went ahead with the routine investigations. The complete blood picture was otherwise normal apart from leukocytosis. He had no thrombocytopenia. His viral screening is negative. So here we proceed with a lumbar puncture, and we had sent blood cultures. Lumbar puncture showed a high opening pressure with 690 cells, which was neutrophil predominant of 80% neutrophils, a low glucose of 30. It's always mandatory to check the CSF to serum glucose ratio, and if it's usually less than 60% and less than 0.4 ratio is indicates a pyogenic meningitis. Protein was high, it was 260, but the gram stain was negative and culture showed no growth. So this patient was empirically started on ceftriaxone and vancomycin pending cultures. The blood cultures and CSF cultures showed no growth. So what do we do next? Should we do any further tests or review the history because cultures are negative? Is there a antibiotic exposure prior? So review of history shows that before coming to our facility, he had visited a local hospital where he had been given antibiotic doses before being shifted here. So that is the likely reason for cultures showing no growth at 48 hours. So with this patient was also started prior to CSF analysis on acyclovir and doxycycline, as he had altered mental status, and before getting the labs, we had started him on the cover for pyogenic, viral, and atypical infections. So the CSF picture shows here neutrophil predominance with high protein and very low glucose. So compared to the blood glucose, it's less than 40%, which points to a pyogenic picture. Now, when we compare it, why the viral and other etiologies are unlikely? Usually viral, predominantly, viral etiologies cause a lymphocytic predominance. with usually normal glucose. So whenever a CSF shows a normal glucose or a very mild reduction and with a mild increase in protein and lymphocyte predominant, viral and atypical infections come into the picture. Usually bacterial meningitis, the polymorphonuclear leukocytes can be very high. The counts can be as high as 1000. Protein can be as high as 500 and glucose very low, even to 10. And other etiologies, it's a very early infection, acute history, hence unlikely. But in tuberculosis and fungal etiologies also, it's a more of a low glucose with lymphocyte predominant and high protein. So next, we center molecular testing, next generation sequencing, which turned out positive for pneumococcal infection, that is Streptococcus pneumoniae. So what is the recommendation for NGS testing based on the latest guidelines by WHO? So it suggests a strong recommendation for individuals with suspected suspected acute pyogenic meningitis, and it should be performed on the CSF sample. Now, result of these tests should be interpreted in context of clinical presentation, and it's always the gold standard tests, cultures and stains should be sent, and additional findings on the CSF should be correlated, as these tests can sometimes be false positive. Hence, clinical correlation along with cultures are mandatory. So the diagnostic yield of PCR tests for bacterial pathogens, when can we see a negative PCR test? When antimicrobial treatment is initiated prior to a lumbar puncture, when the transportation and preservation practices are suboptimal, hence cultures and antimicrobial susceptibility should not be replaced by PCR. In our patient, the CSF culture was negative. It was probably due to the prior antibiotic use. Even a single dose of antibiotic before the lumbar puncture can sterilize CSF rapidly, especially in a pneumococcal meningitis. Pneumococcus is a very sensitive organism. Even a single dose of ceftriaxone can render the cultures negative. Even the next generation sequencing is helpful in our case, as it can still detect minute amounts of material. Early or partially treated infections may have few organisms which are difficult to pick up on a culture growth, but here NGS helps in diagnosing. The other reasons for culture negative could be a suboptimal sample, delay in transporting, or small CSF volumes, which can occur in various settings, which can render culture yield, reduce the culture yield, but NGS may pick up in these scenarios. And some pathogens are hard to culture, in where NGS bypasses the growth requirements, and as it has a higher sensitivity, it can confirm, even when conventional methods fail. Coming to the management principles, in our patient, we had sent in a blood cultures and started empiric antibiotics along with dexamethasone 10 mg per kg every 4th hourly. So whenever a LP is it's not possible to do a lumbar puncture, antibiotics should not be delayed. And other treatment include supportive care, the control of raised intracranial pressure, and anti-epileptics. Now, coming to the treatment for adults with no risk factors from a community, pyogenic meningitis treatment involves ceftriaxone, which is given at a twice daily dosing of 2 grams, along with vancomycin. In settings where there are neonates and elderly, ampicillin in the dose of 2 grams 4th hourly is added to cover possibility of Listeria monocytogenes meningitis, which is a common cause in pregnancy, in neonates and elderly individuals and immunosuppressed hosts. Now, coming to post neurosurgical ventriculitis meningitis and post trauma cases, Meropenem with vancomycin is ideal for treatment to cover gram negatives and pseudomonas in this setting and staphylococcal infection. Moving on to the duration of therapy in a bacterial meningitis, where penicillin susceptible strain, usually penicillin G, for 10 to 14 days. It's ideal to give a 14 days treatment in pneumococcal meningitis. In settings or epidemiological settings of penicillin resistance, ceftriaxone is recommended in 2-gram twice daily dosing for 2 weeks. Where there is a cephalosporin resistance, vancomycin is preferred along with ceftriaxone. Coming to meningococcal meningitis, ceftriaxone is the treatment for 5 to 7 days. A shorter duration, even 5 days, is ideal in Neisseria meningitis according to the latest WHO recommendations. Haemophilus influenza also 7 to 10 days is the duration of treatment with ampicillin, or in presence of beta-lactamase positive organisms, ceftriaxone. So ideally, ceftriaxone and vancomycin is the choice, so that it covers most of the organisms, including pneumococcus, meningococcus, and Haemophilus influenzae. Listeria monocytogenes again, ampicillin along with gentamicin for 21 days, or trimethoprim sulfamethoxazole for 21 days is the treatment modality. Now coming to the supportive therapy, when is steroid recommended? Dexamethasone in the weight-based dosing of 0.15 mg per kg 6th hourly before or with the first dose of antibiotics for 4 days is recommended in all suspected cases of bacterial meningitis. And why is it mandatory to, what is the rationale for giving dexamethasone with the first antibiotic or 20 minutes prior? It is because it inhibits the production of TNF alpha, the cytokines which are released by macrophages and microglia. Only if it is administered before these cells are activated by endotoxin can it prevent the complications due to the raised intracranial pressure and hydrocephalus. Usually, these patients can develop sensory neural hearing loss, and inhibition of TNF alpha and prevention of the inflammation helps in prevention of these hearing sequelae. Once it is given later, it does not alter the production of TNF alpha. Hence, it is not ideal to give it later, as it doesn't help in reduction of inflammation or complications. Coming to the duration of steroid in a bacterial meningitis, for how many days is it recommended, and when can we stop the steroids in a case of bacterial meningitis? So when the CSF findings suggest bacterial meningitis and there is a culture which is positive for pneumococcal Haemophilus influenzae is detected, then it is continued for 4 days. If there is any other bacterial pathogen detected or it's a viral etiology, then corticosteroids can be discontinued. Moving on to a second case. So I'll go ahead with a case where we will focus on neurosurgical ventriculitis, meningitis. We saw this lady recently. She's a 50-year-old female with a known hypertension and presented with accelerated hypertension, sudden unresponsiveness following a fall at home, and was diagnosed with left thalamic bleed with intraventricular extension and a gross hydrocephalus, for which a neurosurgical intervention was done and a right frontal EVD was placed. So she had a very poor GCS. After EVD placement, her sensorium had improved, but 3 to 4 days later, there was a displacement of the EVD and it had to be removed. And there was a left frontal EVD placed, for her. So there was already, she had a right one which was displaced, and hence she underwent a left frontal EVD. Following which she developed after 4 to 5 days low-grade fever spikes. Hence the EVD was removed and her sensorium had dropped. The GCS was poor. On repeat CT, there was a accumulation of bleeding, and hydrocephalus had increased. Hence, there was a right frontal large dome reservoir was placed. The samples were sent from CSF, which showed turbid CSF with very high WBCs. As you can see here, it is 1,61,000 WBCs and neutrophil predominant. Even the RBCs are very high. It's 2,47,000. So in this is a syndrome which is neurosurgical meningitis or ventriculitis, and the clue to diagnosis is whenever there is a patient with a bleed with clinical features of fever, drop in sensorium, hydrocephalus, post neurosurgical procedures, a CSF lactate, glucose and protein are crucial for diagnosis. The CSF lactate here was 18.5, protein was very high, and glucose was very low. It was 12. The recommendation suggests that CSF index, wherein if there is if it's not very clear, a CSF and blood index of more than 5, where CSF WBCs with blood, the peripheral leukocyte count, and CSF and RBC with the RBCs in the peripheral smear, that ratio can, if it's more than 5, indicates a neurosurgical meningitis, and a high lactate gives a clue to the diagnosis. So this patient's culture grew Enterococcus faecium, which was ampicillin resistant. By the, this is when we were involved, and we had she was already on a cover for carbapenem resistant enterobacteriaceae with ceftazidime, avibactam, and astronam. We added vancomycin IV in intravenous and intraventricular through the Omair reservoir, but she succumbed after a few days of infection with a poor, her GCS didn't improve, and repeat cultures persistently grew Enterococcus faecium. So here, this is a classical case of ventriculitis or healthcare associated ventriculitis and meningitis. It's a severe disease that occurs after CNS instrumentation or surgeries, trauma, or device insertion. What is the risk factor in our patient? So the days of catheter days, usually these are common after usually about 5th day of the procedure or catheter stay. And clinically, apart from the clinical correlation, routine CSF sampling, CSF leukocytes, catheter blockage, and intraventricular hemorrhage also are risk factors for neurosurgical meningitis here. There's a study from India, NIMHANS, which showed the most common organisms in early neurosurgical meningitis being gram-negative bacilli, Pseudomonas, Klebsiella. In a late presentation, we see gram-positive organisms like coagulase-negative staph epidermidis, Enterococcus species, and other bacteria. So there is no single marker. How do we diagnose a neurosurgical meningitis? There is no single marker available to diagnose. So always a clinical correlation with CSF analysis and imaging helps. So first thing is to rule out other infections, and diagnosis is difficult due to background of chemical meningitis, where there can be a bleed and it can mimic the CSF picture can mimic due to the bleed and increase in RBCs, lactate and WBCs can present. CSF from LP may miss shunt infections, as ventricular CSF may not be in communication with the lumbar CSF. Hence, it is always crucial to do CSF analysis from the Omair reservoir, that is a ventricular CSF, which is more suggests the pathology. Shunt infections, 20% can have normal counts and lactate. And an increase in lactate can occur in subarachnoid hemorrhage. Hence, apart from the clinical imaging, the CSF glucose and cultures help here, and NGS in many situations where cultures are negative, NGS has helped us in picking up the organism. This this flowchart shows us the diagnostic algorithm where the CSF studies if the gram stain is negative and the ratio of blood and CSF glucose, CSF to blood glucose is more than 0.4 and lactate is less than 0.4, then it excludes the ventriculitis or neurosurgical meningitis, and there's no requirement to initiate an antibiotic therapy. Hence, search for non-infectious causes of meningeal inflammation in this setting. A negative gram stain with the CSF to blood glucose of less than 40% or a lactate of more than 4 or a cell index of more than 5. In this situation, we need to initiate the antibiotic therapy. If cultures are negative, molecular tests may help. If all the microbiological studies come negative, a repeat after initiation of the antibiotics, a repeat CSF analysis after 3 to 4 days is required. And if the CSF analysis shows improving trend, then to complete the duration of antibiotic, it is based on the local prevalence of the bacteria is required. Now, positive gram stain.
Sagarika, 7 minutes now.
Yeah, ma'am. Sure, ma'am. A positive gram stain, which shows, if it shows a gram positive bacteria, then treat according to the epidemiology. And if it's a gram negative, then in our setting, carbapenem resistant enterobacteriosis and pseudomonal specific antibiotics are recommended. The treatment for neurosurgical meningitis in these settings where the targeted therapy for Staph aureus, if it's a sensitive to methicillin, nafcillin, oxacillin, plus if the shunt or drain is present, rifampicin can be included. Alternatives are linezolid, daptomycin, and trimethoprim sulfamethoxazole, which has a good CSF penetration. For methicillin-resistant Staph aureus, vancomycin, and if shunt or drain is there, plus or minus rifampicin. Again, alternates if there is a situation where there is a AKI or a creatinine rising trend of creatinine and intolerance to vancomycin, alternatives like linezolid or daptomycin can be considered. So, carbapenem resistant Acinetobacter treatment includes intravenous and intrathecal colistin along with ceftazidime, aztreonam or fosfomycin, minocycline and tigecycline. So in this setting, it's always crucial to check for minocycline sensitivity. It's an unsung hero in our setting and it has a very good CNS penetration, and along with colistin, it makes a good combination for neurosurgical meningitis. Carbapenem resistant Pseudomonas infections can be treated with colistin, again intraventricular and intrathecal, along with fosfomycin if susceptible. Interventricular antibacterial therapy should be considered for patients in this setting with poor, as systemic antibacterial therapy alone has poor CSF penetration. After administration of intraventricular therapy, the drain should be clamped for around 15 to 60 minutes to allow the agent to equilibrate thoroughly in the CSF, such that it can achieve a more than 10 to 20 times MIC of the drug in the carbapenem resistant meningitis secondary to gram negative organisms. The duration of therapy in gram negative bacterial meningitis is 21 days. And in repeatedly positive cultures, CSF culture should be continued for at least 1 week to 10 days following the last positive culture. And in gram positive, usually a 14 days course should suffice. So to summarize, acute pyogenic meningitis is a emergency situation where rapid recognition and treatment are crucial. Empiric therapy is guided by age and risk factors. Dexamethasone reduces neurological complications, but it should always be considered in the correct clinical setting and should be discontinued if pneumococcal and Haemophilus influenza is ruled out. Prevention via vaccination and chemoprophylaxis is mandatory, as these are vaccine preventable infections, and hence the incidence of these can be reduced, and chemoprophylaxis of close contacts helps in preventing the illness in these situations. So thank you for patient listening, and I'm happy to take questions.
Thank you, Sagarika. It was a very comprehensive presentation of bacterial meningitis, including neurosurgical meningitis. Thank you. There are a few questions in the chat box. One says, do you recommend wet mount in all these patients who come with acute pyogenic meningitis-like picture?
So, in the epidemiological setting where there is exposure to fresh water, and from the states like Kerala, South India, I would recommend in such settings in pyogenic meningitis definitely a wet mount to rule out the amoebic etiology.
Yeah. So, amoebic meningitis can present just like pyogenic meningitis,
Yes.
and it's a low cost test. So it's always good to do a wet mount in all patients of suspected meningitis. And there are also many instances where amoebic meningitis can coexist with the pyogenic meningitis. So it is always a good practice to do wet mount in all suspected case of community acquired meningitis. And there's a question on CSF biofire. So, what is your idea about multiplex PCR versus NGS?
So, multiplex PCR has a wider variety of organisms, and in a setting of pyogenic meningitis, where it's a partially treated case, it's always helpful in this setting. So we always do back like the NGS multiplex PCR.
So, don't you go for multiplex PCR like such as biofire?
So first, ma'am, biofire in cases where it comes as a negative biofire results, in those settings we send a multiplex PCR outsource, as it has a wider organisms in the base. So in settings where
the question is the sensitivity of this even NGS will decrease with the use of antibiotics. So,
yes,
which sample do you choose?
So it's always ideal to do the in-house PCR, which is standardized.
You mean to say the some replacement or the in-house PCRs? How many bacteria are targeted with that? Bacteria or viruses?
In-house PCR, the common etiologies of bacterial, viral, and atypical organisms are included. Apart from that, in patients where we suspect pseudomonal or staphylococcal infection, there we try to do the bacterial panels, the identification panels, where we outsource.
Yeah.
So
here you should be preserving the initial sample.
Neurosurgical meningitis, it helps us more.
Is it the initial sample itself which is preserved in the laboratory, which is sent?
No, ma'am, we always go ahead. It's ideal to do a fresh sampling for the NGS, but most of the times a repeat LP, if not performed, we send the initial sample itself. But it's always better to go ahead with a fresh CSF sample for the better diagnosis.
Yeah, thank you. I think we are just in time for the second talk. So let us close this session. You can look through the chat and you could try to answer the questions which have not been answered. Thank you once again.
Thank you so
very
much, ma'am.
much.